Actually, we have already discussed different aspects of nutrition, and also nutritional disorders, particularly severe acute malnutrition, moderately acute malnutrition, all discussed previously. Now we are discussing about the vitamins. Vitamins, you know that there are two types of vitamins. One is fat soluble, other is water soluble vitamins. All these vitamin vital amines, they are very much important. They help various roles. And what are their roles, that will be discussed today, the different vitamins. Now we are concerned now with the vitamin A. The fat soluble vitamins are vitamin A, D, E, K. K. And water soluble vitamins, you know about the vitamin C. So we are discussing now the vitamin A. Now this is the chemical formula of vitamin A, and most common form of vitamin A means it is an alcohol and called retinol. You see the last point, this is OH group, it means it is an alcohol. OH group functionally means from your pre-MBBS level, you know it is OH group means alcohol. It's called retinol. When this OH group is converted to CHO group, that is aldehyde, then it is called retinal. And when this OH group is converted to COOH group, that is acidic group, it is called retinoic acid. So there are three important forms of vitamin A. The most important derivative is retinol, then retinal means aldehyde, and retinoic acid. What is the importance of the mentioning of this retinal and retinoic acid, etc.? Is that the retinal and retinol conversion is very much important for generation of energy, particularly for vision purposes. I will discuss this. And retinoic acid is a very important acid which can penetrate the nucleus, attached with the gene, and controls near about 35 modalities of action of the gene. Besides this OH and CHO and OH and retinoic acid, we have to also consider about the retinoic acid ester. Usually retinoic acid, any acid is not free in the body. It reacts this retinoic acid or alcohol. They usually, suppose the retinoic alcohol, retinol, that reacts with one other acids or other say fatty acids and forms an ester. That is called retinal ester. This retinal ester is stored in the liver, in the stellate cells of liver, and it is released when it is required. Let us go to the next step. These are the sources of vitamin A, and you see there are the two important sources are there. One is from the yellow food, known as carotene containing foods or carrot foods, and in the animal foods like say yolks, meat, fish, etc. Now, plant source, that is the carrot, is the important source of vitamin A, and of which the most important is beta carotene. This beta carotene is a very important source of vitamin A, and beta carotene, you see, it is broken down or hydrolyzed and produces the two molecules of retinal, which is subsequently converted to retinol. So the beta carotene one molecule gives rise to two molecules of vitamin A. So that's why it is called provitamin A or vitamin A precursor. One may ask you, what is the name of provitamin A? It is a beta carotene because it's vitamin A precursor. Retinol and retinal, they are interconvertible. I have just discussed that whenever necessary in the body, retinol is converted to, there is alcohol is converted to aldehyde. So here is the retinol is converted to retinal, and the enzyme requires is dehydrogenase. We do not remember this enzyme. It is required for eye ophthalmology, for eye purposes. And this is another thing, is retinal is converted to retinol. So this conversion, retinal and retinol, they may be converted to each other with the help of the different enzymes. This is important. And retinal, the aldehyde is converted to retinoic acid, and there is also another enzyme is required. This is again the absorption other things of retinol. Now in animal foods, what we have seen just now, the source of vitamin A is retinol, that is alcohol group, and the retinol reacts with, I have just told you, it reacts with the different acid and forms retinal ester. So here is the ester is formed, and this ester formation occurs in the intestine. So this is the intake in the gut. This is animal foods, and animal food contain retinol and retinal ester, and they are converted to retinol. Again in the intestine they form the retinal ester. Retinal ester is carried by the chylomicron, stored in the liver in the stellate cells, and when it is required, it is released from the liver when there is deficiency as retinol, and retinol binds with retinol binding protein that circulates in the blood. In the target cell of tissue, retinol is converted to retinal and retinoic acid. In the plant food, beta carotene is converted to, say, retinal, which I have discussed in the previous reaction, and this retinal then converted to retinol, and then it follows the same path. So two important considerations you should remember. The retinol is the main vitamin A, and it may be converted to retinal, the aldehyde, or retinoic acid as per requirements in the body. This you see the two important, two famous scientists. One is Hopkins, got Nobel Prize in 1929 for physiology and medicine. What he said, that during that time it was not only three important sources of nutrition. There's protein, fat and carbohydrate. Hopkins first gives the idea, he gave the idea that it is not only these, there must be some other factors which are required for the human body. Nobody knows what are those factors. So first, there is provocation of thought that there are some other factors which are required other than this protein, fat and carbohydrate. And he shows various experiments that these are required, otherwise the animal cannot survive without that. And got Nobel Prize for that. Another one, George Wall, in 1967, got Nobel Prize. Again, and what he did during the Second World War, when the German people are bombing the Europe at night, and the fighters on the behalf of Europe, they are not looking at they are not detecting where from the bombs are coming. That is, night vision were defective. Now he proved an he proved a synthesis. He gave various vegetables to the advised government to supply the various vegetables, mostly carrots to the fighters, carrots. And they take huge amount of carrots. And there is drastic improvement of the vision. And they can control the war. And for this contribution, that carrot is giving the vitamin, carrots is giving something to the fighter, which is improving the night vision. This is the contribution of this scientist, and he got the Nobel Prize. So this is the vitamin A requirements in infants and children. This you can remember just like vitamin D. Vitamin D requires 400 international unit. Vitamin A to some extent 400 to 800. Now, if there is vitamin A deficiency, then there is some changes in the eyes. And these you should commit from them. It's very important. And everywhere it may be asked in the exam also, various places. In different questions and others. Now you see the first one is most important earliest sign is the night blindness definitely. The symptoms of it. And primary things, as per the WHO, primary changes and secondary. These are the secondary changes. What are the primary changes? Primary changes is conjunctival xerosis, and there is bitter spot, corneal xerosis, and then corneal ulceration. Less than 1/3 or more than 2/3, and more than 1/3. And ultimately, what will happen? There will be corneal keratomalacia, corneal sopping due to ulceration. Now, secondary changes are say night blindness, fundal sclerosis, and corneal skull. So remember, till now, in spite of all this knowledge, in spite of various programs, till now, large number of people, they are suffering from vitamin A deficiency, characterized by the prevalence of night blindness as well as level of the vitamin A in the serum. It's very good. This is conjunctival xerosis. You see, this is conjunctiva. This is cornea. This is conjunctiva. Conjunctival xerosis. This is you see the bitter spots in the temporal aspect of the eye, more or less triangular shiny spots, bitter spots. This is corneal xerosis. Corneal part is dried. Corneal ulcer. So why this xerosis? The epithelium is not maintained. Epithelial integrity is not maintained in vitamin A. Actually, vitamin A helps in maintaining the integrity of the epithelial cells. Integrity of the epithelial cells, those who are adherent to each other, they are adherent to each other. Why? Intercellular adhesion molecule or ICAM molecule. Intercellular adhesion molecule or ICAM molecule. These molecules is activated by vitamin A as well as vitamin A is again moved from the liver to periphery with the help of zinc. So zinc and vitamin A, those two are required for maintaining for integrity of the epithelium. So as the integrity of the epithelium is lost in vitamin A deficiency, so you will not see the other things like say conjunctiva, very rapidly changing epithelial cells, they are damaged. Then the growth may be arrested. Why the growth may be defective in vitamin A deficiency? This is important. Now retinol and retinal is converted to retinoic acid. I have told you, retinoic acid penetrates the cell's nucleus and attaches to the gene. And retinoic acid releases growth factor, different growth factors that helps in the growth of the subject. So if the vitamin A is deficit, retinoic acid is not properly formed and growth factors are not properly formed and growth will be reduced. Thus, as it maintains the integrity of the epithelial cells, so fertility is also controlled by the vitamin A, and its deficiency is one of the important causes of infertility. Immune response requires the movement and division of the cells. That requires also vitamin A. So, indicators of vitamin A deficiency, two important indicators. I have told you what is about the night blindness prevalence and serum retinol concentration. If the serum retinol concentration is less than 0.70 microgram per liter, then it is considered that there is vitamin A deficiency. Other factors like zinc, iron, etc., that should also be measured, and they may be considered as some factors which may hinder the measurement of vitamin A deficiency. So these are also important for measurement. Now this is the treatment of vitamin A deficiency in relation to the age. You see less than 6 months. This you know from the previously, you probably you have read it. The vitamin A deficiency is less than 6 months, 50,000, 6 to 12 months, 1 lakh, and 12 months to greater than 12 months, 2 lakhs units. And if as you are treating the patient who is suffering from vitamin A deficiency, you should repeat on the next day and 2 weeks later every cases. So this you should remember for day-to-day practice. International 50,000 international unit previously shown. Vitamin A is measured as a unit, international unit, and daily requirement is 400 to 800 international unit. Okay, so whenever there is a deficiency of vitamin A, you should treat the child with either less than 6 months, 50,000, repeat on the next day, and 2 weeks later you should repeat. 6 to 12 months, 1 lakh unit, repeat on next day, and 2 weeks later you should repeat. And 12 months to 2 lakhs, it is repeat on the 2 lakhs, 12 months, and repeat on the next day, and 2 weeks later you should repeat. Okay? So, this is the treatment of the cases where the child is suffering from vitamin A deficiency. Now, there is another term, the hypervitaminosis A. Sometimes if you give the excessive dosage of vitamin A, large amount of vitamin A doses, if you give, that can give rise to hypervitaminosis A. Two important considerations are important. One is pseudotumor cerebri. It looks like the pictures are looks like say benign intracranial tension. There are some substances which can give rise to benign intracranial tension. They are not really raising intracranial tension. Intracranial tension means tension raised inside the brain, and this intracranial tension depends on the CSF weight as well as brain tissue, etc., and the blood supply, any other external factors present there. Suppose some tumor, brain tumor is present, and it is compressing the brain tissue, there will be raised intracranial tension. But benign intracranial tension means there is nothing organic in the brain, but till the intracranial tension is raised. And pseudotumor means looks like a tumor, but is really not tumor. So this is pseudotumor cerebri or benign intracranial tension. Now in this sense, usually in case of say intracranial tension, there will be papilledema. If you examine the cornea, you will see cornea is edematous, papilledema. That papilledema is not usually seen in pseudotumor cerebri or benign intracranial tension. It may be seen in say really real endocrine tension. Not usually, but rarely that can give rise to this. In addition to that, the child will vomit. You will get the history. Suppose a child is 9 months and during vaccination and the program, vitamin A is given 2 lakhs unit or 1 lakh unit say. In 9 months 1 lakh. After that 2 lakh unit. Now this we say unit is given vitamin A and huge amount of vitamin A can give rise to vomiting of the child. 1 or 2 day vomiting. That is not bad. That will usually improve after some times. There is also another problem that is called hyperostosis or Caffey's disease. This Caffey's disease. The hyperostosis is called a painful condition of the bones. Painful condition of the bones. There is some deposition of the bony tissue that can give rise to painful condition of the bones, and that is called hyperostosis or Caffey's disease. So the most important thing, you should not allow for the deficiency of vitamin A. You should prevent the deficiency of vitamin A. How you can prevent? And we have the guideline from National Medical Council. And when you see there is some measles or severe acute malnutrition, less than 1 year you should give 1 lakh unit on day 1 and day 2. And if it is a persistent diarrhea or prolonged febrile conditions, then same dose, day 1. Second dose should not be on day 2, but should be after 1 month. So see, they are giving most important in the measles and severe acute malnutrition, because second dose is given on day 2. In other cases, it is given after 1 month. The other two. Vitamin A prophylaxis just I uttered. It should be between 9 months, 1 lakh unit and 2 lakh units at second. 2 lakh unit at the 16 to 18 months booster. Huh? This prophylaxis means vitamin A, National Vitamin A Prophylaxis Program. National Vitamin A Prophylaxis Program. It is given 9 months, 1 lakh unit and 2 lakh units at first booster time, and then every 6 months up to 5 years of age. So what is the main purpose of this total thing? The prevention of vitamin A deficiency. From any part of this, you may ask any questions from this. Prevention is very important. It may be in relation to the measles, it may be in relation to severe acute malnutrition, persistent diarrhea also. So we are going to our next form, that is vitamin D. Vitamin D. Vitamin A has already covered few important points. We are going to next vitamin D. Vitamin D, you know, is very important. Vitamin D and is concerned mainly with the calcium, phosphate, parathyroid hormone, bone mineral metabolism, kidney regulations, intestinal regulations. Vitamin A is concerned with. Vitamin D concerned with. Vitamin D, previously known as vitamin D1, D2, D3. The physician from France first recorded the vitamin D, who discovered the vitamin D. He said first thing is a cholecalciferol vitamin D1. Subsequently, we take the argocalciferol from plant is vitamin D2, and again determined that no, the vitamin D source from animal that also contains some cholecalciferol. So D1 and D2, D1, D2, D3, D1 cholecalciferol, D2 argocalciferol, D3 is also cholecalciferol. So D1 is misnomer. So we do not use the D1 term now, because D1 cholecalciferol and D3 is also cholecalciferol. Okay. So the physician who first discovered vitamin D, He said that there are three types of vitamin D, D1, D2, D3. Subsequently, on analysis, it was found D1 and D3 are same chemical structures. There is cholecalciferol, and D2 is argocalciferol. D2 is the plant source of vitamin D, and D3 is the source from the cell. There is exposure to skin, exposure of ultraviolet light or sunlight to the skin. Now, what are the chemical main forms of vitamin D? Cholecalciferol is known as the D3. Argocalciferol is D2. Actually, argocalciferol does not present in the body as D2. It is converted to D3 or cholecalciferol. And calcitriol means 125 dihydroxy cholecalciferol, and calcidiol means 25 hydroxy cholecalciferol. Now D1 exists. D1 is equal to D3. Okay. Now this side is clumsy. We are not discussing this. I just tell you what may be the different sources of vitamin D deficiency. Suppose a child is not giving sufficient amount of exposure, or person is not exposing to the sunlight. What is happening in the sunlight in the skin? There is a 7-dihydrocholesterol. 7-dihydrocholesterol, which is converted on exposure to sunlight to cholecalciferol or vitamin D3. And this sunlight is usually after 11 a.m. to within 3 p.m. And the ray is known as ultraviolet B radiations. Nanometer is 260 to 310. If you give exposure before 11 a.m. or 10 a.m., that is not helpful. Even if you give the exposure after 3 p.m., that is not helpful. Okay, so helpful exposure is 11 a.m. to 3 a.m. Now within this period, if you give the 30 minutes exposure to the skin and 40% of the skin surface is exposed to the sunlight, that will give rise to synthesis of vitamin D for 1 week. But people are very much concerned about the exposure to sun. In some areas, say it is also difficult for exposure because of the ultraviolet induced skin cancer and skin changes and photosensitivity, allergic to sunlight. Now second, so if the exposure is not proper, then vitamin D will be deficient definitely. Or if the person is not taking sufficient amount of the animal food or plant food which contains vitamin D, so they also suffer from vitamin D deficiency. Again, they suppose there is some vitamin D when it is metabolized, it will first go to the intestine. It is a fat soluble vitamin, just like vitamin A, and that requires the help of the bile salt. And they form the micelle in the intestine and absorbs in the chylomicron. So if the fat soluble vitamins, as it is fat soluble vitamin, so if there is fat malabsorption or malabsorption syndrome in the intestine, vitamin D will be deficient. Similarly, vitamin D or cholecalciferol first go to the liver for 25 hydroxylation. So vitamin D, cholecalciferol, first from the intestine, it is carried to the liver where it is from 25 hydroxylation. So if the person is suffering from some chronic liver disease, definitely that hydroxylation will not occur. So that person will suffer from vitamin D deficiency. Again, after 25 hydroxycholecalciferol, vitamin D goes to the kidney, where the proximal tubular cells mostly, they convert the 1-hydroxylation. So 25 hydroxylation occurs in the liver and 1-hydroxylation in the kidney, proximal tube. And that gives to 125 dihydroxycholecalciferol. So if the kidney is damaged, kidney is suffering from some diseases, okay, then vitamin D deficiency will be there. Again, the parathyroid hormone helps in the activity of the vitamin D. So, so if the parathyroid hormone is not producing properly, hypoparathyroidism or other things, vitamin D absorption will be hampered, balance will be lost. So large number of causes can give rise to vitamin D deficiency. And now this is the different sources of vitamin D. I have discussed with dietary source, mainly of the aquacultural plant sources, animal sources, the cholecalciferol, discussed it. And 7-dehydrocholesterol ultraviolet seen from the cholecalciferol. In the liver, it converted to 25 hydroxylase, and in the kidney, it is converted to 125 dihydroxylase. This is the important form of the vitamin D. And this 125 dihydroxy vitamin D or cholecalciferol that helps in absorption of the calcium from the intestine. It helps in the bone resorption for balancing of the calcium and phosphate in the blood, and also it helps in the deposition of the bones by osteocytes activation, and it decreases the renal excretion of calcium and phosphate. So these are the function of the vitamin D in the tissues, in the intestine, in absorption of calcium, in the bone synthesis, bone deposition and resorption, both factors. And in the kidney, it reduces the excretion of the calcium and phosphate excretion. So decrease of both calcium and phosphate. These are the functions. Suppose large amount of vitamin D, if it is formed, then it automatically, this is activated. This enzyme known as the 1-hydroxylase enzyme, which convert 25 hydroxylase vitamin D to 125 dihydroxylase hydroxyvitamin D. The hydroxylase enzyme is secreted in the proximal convoluted tubule epithelial cells, and that is activated by parathyroid hormone. Okay, so if there is sufficient amount of vitamin D is formed, then what will happen? Then that will prevent the feedback inhibition that decreases the synthesis of parathyroid hormone and decreases the activity of 1-hydroxylase. So vitamin D activation is, if there is a control by the self-regulatory mechanism by feedback inhibition to 1-hydroxylase. Similarly, if till there is large amount of vitamin D is formed, it is converted to inactive vitamin D by the formation of this compound 24-25 dihydroxyvitamin D. It is 24 hydroxylation occurs in vitamin D. So 125 is converted to inactive form 24 hydroxylase. There is another factor that is not mentioned here, that is called fibroblast growth factor, FGF, fibroblast growth factors. That also helps in the formation of inactive form of the vitamin D. FGF, fibroblast growth factors. Sometimes this fibroblast growth factor may be overactive by the profuse genetic expression that can give rise to vitamin D deficiency by inactivating this 125 hydroxyvitamin D. Is it clear to you? So this is the total metabolism of vitamin D pathway. Sometimes it may be asked in the theory also, or maybe in the short form, small questions may be there. So this is, you see, that's I discussed before, that is written here, the vitamin D metabolism. You see, renal enzyme 1-alpha hydroxylase and 24-alpha hydroxylase. Renal 1-alpha hydroxylase is very important. This is important. This renal 1-alpha hydroxylase is controlled by the parathyroid hormone PTH and serum calcium and phosphate and fibroblast growth factor. Okay. So if there is large amount of serum calcium and phosphate concentration, that will inhibit the vitamin D formation pattern. The deficiency of vitamin D can give rise to rickets. Calcipenic rickets means what the child is growing. Rickets is a disease of growing bones. When the child is growing, there is calcipenic deposition of minerals is calcium and phosphate, and mineral is deficit, calcipenic rickets. But when the growth is complete, then it's called osteopenic rickets, means osteomalacia. Now, bone formation, you know the three important steps there is. You should remember, first step is the proliferation of the chondrocytes in the growth plate. In the growth plate, chondrocytes, that is the cartilage, they are proliferated. Second thing, there is definitely mineralization, and that requires the vascular proliferation. If any of the steps is deficient, the mineral is not available. If the growth plate is not properly formed, cartilage are not properly formed, or if the vascular vessels are not properly formed, that can lead to defective bone formations. Now, in the important clinical pictures of vitamin D deficiency, important clinical pictures. What are the important clinical pictures of vitamin D deficiency? First important thing is delayed closure of the fontanelles. And the rickets, there is some macropephaly or large head. Fontanelles are not properly closed. There may be some washing of the frontal and parietal bones. Frontal bones are washing, forward protrusion. Parietal bones forward protrusion. That will happen in the case. And you see the teniotaps. Teniotaps, soft skull bones. Teniotaps. It means that just like ping pong ball you see, ping pong ball. Now, for MCQ purposes, what is the first clinical findings of vitamin D deficiency about rickets? You should answer teniotaps. Teniotaps is the most important and first clinical findings in children for vitamin D deficiency. Though it is mentioned in the third, but the first clinical findings. Now, enlargement of the costochondral junctions visible as bleeding anterolateral space of the chest, like rosary. I will show the picture of rosary. So go there and see the rosary. Costocartilage here, this is cartilage, here the bones. Now these are the costochondral junction, and you see rachitic rosary. Rosary means Rudraksher mala, gold. Rudraksher mala pore thake oneke. Rudraksher mala, rachitic rosary. Now here the differentiation will come from scorbutic rosary. This is rachitic rosary, round, costochondral junction. In scorbutic, vitamin C deficiency, you will get same type of swelling. But that swelling is not round, there is a cut point. One side is fat, and that is also tender also. This was scorbutic closure. This is the fontanelle, we just say enlarged fontanelle, indicates frontal bossy and parietal bossy. Rickets findings. Bow legs. You will see some children with this type of findings due to rickets. Now, this is you see the classical X-ray findings of rickets. Now, as the cartilage are say Present in the, you know, here the site of cartilage present, like epiphysis. Below the epiphysis there is metaphysis and there is diaphysis. Now the cartilage, there's adequate mineralization is not there. So because of the pressure, then what will happen if the mineralization is not there? There will be widening of the bone, lower end of the bone, or the end of the bone. There is a widening. There is the widening of the bones. You see. Now you see there is some irregular margin. It's fraying of the bone. So an adequate mineralization is not there. You will see. So fraying, widening of the bones is very important. And there is also some depression or carp, you see. Okay. So if you find this type of X-ray, you can say this is a case of rickets. The X-ray shows like this. This is the X-ray of the bone X, which I have shown. You show this type of X-ray, it's a bone X. Now requirement, you know the requirement of infant, and then from newborn onwards up to the age of say 1 year, it requires 400 international units, and we should start it. Then after 600 units to 800 units vitamin D requirement. Now vitamin D deficiency. When you stamp the case as deficiency of vitamin D, you will have to measure the vitamin D status. Which vitamin D is usually measured for vitamin D status is 25 hydroxy vitamin D. And vitamin D deficiency is when it is less than 12 nanogram per milliliter. Insufficiency 12 to 20, and sufficiency above 20. And huge amount of vitamin D persisting for more than 100, 200 or 300 can give rise to toxicity of vitamin D. Now here is the treatment of say rickets. Previously the treatment was that when we are students or house physician, we usually use this STOS therapy. STOS therapy. It means you give large amount, we usually give large amount of vitamin D. 6 lakhs of vitamin D, waiting for 4 to 6 weeks, see whether there is a healing calcification, healing of the bones occurring or not. If it is not, we can repeat another dose of 6 lakh units and another say 1 month. If still there is no improvement, it is resistant rickets, vitamin D resistant. But, so that is called STOS therapy, but that therapy is obsolete with that high dose. STOS therapy is still there, but with not so much high dose of vitamin D. There is some changes. For the usual treatment, what you should do, go slow. Go slow, you give the 2000 units in infants daily for 6 to 12 weeks. And followed by maintenance. This is the important fact. If it is the older children, more than 12 months, more than 1, you give 3000 units for 12 years, that is 3 months, followed by maintenance of 600 units. Very easy to remember. And children with rickets, dose is double, 6,000 units, 3 months, followed by maintenance. And serum vitamin D level should be monitored every 2 months. And remember, the calcium supplementation should be given concomitant at 50 milligram per kg, maximum 500 milligram. And you should follow up the child. You should not allow the vitamin D huge dose for a long time, or calcium huge dose for a long time. That can give rise to calcinosis. It means calcium will be deposited at the different tissues. In the kidney, it can give rise to nephrocalcinosis. It may be deposited in the brain, giving rise to calcinosis in the brain, giving rise to various features. So this calcinosis you should not allow large amount of vitamin D doses. This is STOS therapy. Previously I told you that we use huge amount of dose Nowadays it is not. It is, dose is to some extent low. Now, high dose of vitamin D therapy is known as cross therapy. Less than 3 months, it is not recommended. From 3 to 12 months, single dose of 50,000 units. 1 to 12 years, 1.5 lakh. Single dose, and more than 12 years, 3 lakhs. So it is not 6 lakhs, 3 lakhs. No, more than 12 years. And 1 to 12 years, 1.5 lakhs. So these are the cross therapy, large amount of dose in single time. This is useful where there is compliance is poor. Suppose the patient, whether the child will take medicine or not, there is some doubt. In that case, you should follow this. This is again the same thing. This is not required recommendation of vitamin D. And the hypervitaminosis D, we have discussed that if you give huge amount of vitamin D for a long time, that can give rise to various problems. Calcium deposition here and there, it can give rise to cardiac arrhythmia, and in brain it can give rise to irritability, electrolyte disturbances, and calcium may be excreted in the urine, known as hypercalciuria, one of the important cause of hematuria. Hypercalciuria invites RBC and that can give rise to hematuria, an important cause. It can give rise to GI manifestation, vomiting, diarrhea, etc. So we do not require hypervitaminosis D also. Okay. So these are these two vitamins we discussed now today. Time is up. Only for the last 5 minutes I will just repeat some two vitamins with some questions. What is the chemical name of vitamin A? Vitamin A, retinol, correct answer. So correct answer is retinol is the chemical name. What are the different varieties of vitamin A? Retinol तो बोलो तुम retinoic acid, yes, आठवां बोलो, yes, retinol, correct answer. So retinol, retinoic acid, ester. These are the difference from vitamin A. Where the retinoic acid ester or retinoid palmitate usually, palmitic acid, where it is stored? Liver in which cells? MC4 cells, stellate cells of liver, the retinoic acid, vitamin A is stored. How the vitamin A is released? Vitamin A is released with the help of a protein known as vitamin A is released from the liver with the help of a protein known as बोलबे ना जे जानो बोलबे ना बोलो retinol binding protein or RBP. Suppose a child is suffering from severe proteinuria malnutrition, retinol binding protein may be deficient. In spite of vitamin exposure, sometimes that will not be active because RBP is deficient. We will carry the vitamin. Okay. What is the earliest sign of vitamin A deficiency? Earliest sign. আমি বলেছি তখন earliest sign, night blindness, earliest sign, তাই তো না xerophthalmia তো গোটাটা earliest sign is night blindness, earliest sign of vitamin A deficiency. ঠিক আছে বেশ when from vitamin A prophylaxis will start from which age? From vitamin A prophylaxis will start from National Vitamin A prophylaxis program will start from which age? Just from prophylaxis program. 9 months, 1 lakh unit. Then second dose is 16 to 18 months with the first booster. Then every 6 months for 5 days. Up to 5 years. Is it clear to you? In case of measles, what is the vitamin A treatment should be given? How much? Vitamin A. In case of measles, harm. Vitamin A কিভাবে দেবে? না শুধু দেবে, পড়ালাম তো, বলো। Less than 1 year? Day 1 and day 2, less than 1 year, 1 lakh unit, more than 1 year, 2 lakh unit. একটু আগে পড়ালাম না, in case of measles and severe acute malnutrition. ঠিক আছে? In case of, say, prolonged febrile illness, what should the dose? Day 1 and after 1 month. Day 1 and after 1 month. Same dose, but day 1 and after 1 month. ঠিক আছে? Six months and less হলে কতটা দিতে হবে? 50,000. 6 months to 1 year, 1 lakh. More than 1 year, 2 lakhs. ঠিক আছে, লেখা ছিল, দেখবে পরে। Now, what disease will appear in vitamin D deficiency in growing child? What is the name of the disease? What is the name of the disease? No. What is the name of the disease which occurs in growing child with vitamin D deficiency? No, can you give the earlier sign? Rickets. R-I-C-K-E-T-S. No, earlier. What is the disease? Name of the disease? R-I-C-K-E-T-S. S টা দিতে হবে last. Rickets. ঠিক আছে? So rickets is a disease which is growing child with vitamin D deficiency. In adult, vitamin D deficiency gives rise to which problem? Osteomalacia. ঠিক আছে? What is the earliest signs of vitamin D deficiency in children, infant? বলবে না। Earliest sign of rickets in infant. Earliest sign of rickets in infants. Carotenoids, ping pong. No. Carotenoids, ping pong. No, carotenoids বললাম তো। Earliest sign. Yes. What is the status of fontanelli in rickets? Fontanelli rickets. ছোট হয়ে যাবে না বড় হবে? Fontanelli rickets.